So welcome everybody. We're going to have a fun talk tonight on something that's quite interesting, that I find quite interesting. Dr. Wadha AlSaadoun will be giving us a talk on iris defects, overview, and management pearls. Wadha is our current fellow, and I first met her a few years ago in Kuwait, where she caught my eye because of how she was absolutely crushing her exams and her clinical rotations in Kuwait. And we're very fortunate to have her with us as a fellow. And so, you know, she's learning here, but we're also learning a lot from her. So I'm really pleased that Wadha, you'll be talking about this. So without any further delay, let's hear what you have to say about iris defects.
Thank you, Dr. Baig, for this great introduction. I have the honor now with working with you and the rest of the team. I'm learning a lot. So I'm going to start to talk today about iris defect, things that I have learned basically here in Canada. So my objectives today are going to be systematic approach to managing small and large iris defects, discuss the basic suturing techniques, including McCannel, Siepser, Imbrication Suture, Iridodialysis Repair, Pupillary Cerclage, prosthetic iris devices for large iris defects, and differentiating therapeutic iris implants from cosmetic implants. Iris defects, as we know, can be congenital or acquired. Congenital iris defects include aniridia, iris coloboma, patients with albinism where they have a good stroma but they don't have a functional pigment epithelial layer. Acquired causes include penetrating and non-penetrating iris injuries, iatrogenic surgical excision of iris lesions, PIs, whether surgical or laser, trauma in the anterior segment surgery, and post-inflammatory uveitis where we lose a lot of our pigments. Treatment options include non-invasive glasses, tinted contact lenses. We have many suturing techniques, repairing the iris. Basically, this is a surgical video by Dr. Baig here in the Eye Institute, where he actually did the 3 suturing techniques. First of all, he's stretching the iris to check the viability of the tissue. First knot will be a Siepser knot because it's a more central. He pulls out the suture and tie it outside, and then cut it from inside, a McCannel, and then now doing the iridodialysis repair, where repositioning the iris root to its base. So this was a very fast video. We'll go into details for the surgical techniques. We can also, a very important trick that I learned in Canada, that when patients come to us in the clinic with PIs for narrow angles glaucoma, they have a laser peripheral iridotomies. Here, this is a higher magnification of the same patient. This is the transillumination defects. Patient complains of monocular diplopia, glares. A very important trick that I learned is to just freeze the eye with any topical anesthetic drop, use the surgical sterile marker and color that area, and then ask the patient to go out. If the patient is symptomatically better, then this is a good patient, a good candidate for actually corneal tattooing. As we can see here, this is the corneal tattoo, and this is a higher magnification of the tattoo. This is a pocket created. I don't know if you can see my pointer. So this is a pocket created here in the cornea, and ink injected. No more transillumination defects, and the patient is symptomatically free now, with only a non-invasive procedure at the corneal plane rather than going intraocularly. This is very different from cosmetic tattooing. This is a patient who presented to Dr. Ziaiz in the Eye Institute, who tried to tattoo her sclera. Iris reconstruction, I will talk about the techniques for repair, is based basically on the symptoms, the symptomatic complaints of the patient. Many symptoms such as glares, starburst, photosensitivity, monocular diplopia, decreased visual acuity and quality, loss of contrast sensitivity. The technique of repair also depends on the relative health of the remaining iris and its anatomy, if there is any remaining iris, and the quality, options and resources available for the surgeon, and even the patient desire choice among the available options. Some patients only are very functional, they don't care about the cosmesis. Other patients are very they're meticulous and they want a perfect cosmesis. If you decide to proceed with iris reconstruction, then it's better to have your iris defect toolbox ready. You're going to need either a bond hook, Coughlin hook, or a condon snare. You're going to need a 10-0 proline suture on a long needle, whether it's straight or curved. You're going to need the microsurgical instruments, the MST microsurgical forceps, and a 23-gauge scissors. You're going to need the dispersive viscoelastic, and you're going to need the 27-gauge cannula to duck your needle out, not to catch any fibers of the cornea. I'll start with McCannel basic technique. First, McCannel introduced the concept of suturing the iris within a contained anterior segment by retrieving needles from small incisions. Definitely you need a 10-0 proline suture. In McCannel technique, we create an additional paracentesis nearest the desired knot. Knot is tied and cut flush to the surface. The knot and the reapproximated iris tissues are then reposited into the anterior chamber. So, as you can see here, do you see my pointer? Do you see my pointer? So, here...
Yes, so that we can see your pointer.
Okay, so here you can see the 10-0 needle. This is a curved needle engaging the proximal iris and the distal iris going out. And then an additional paracentesis is created here, pulling both ends. It's a 90 degrees to the suture that we have placed, tying the knot outside the anterior chamber and then repositioning the iris and the knot back inward. Here you don't need an MST, you don't need MST instruments because we're cutting the needle outside, we're cutting the knot outside. Siepser knot. First Siepser described the closed chamber in 1994. You definitely need MST scissors to cut the knot intracamerally. It's applicable for all iris defects, especially the more central ones where you can't stretch the iris to cut tie the knot outside and cut it outside. Again, engaging the proximal iris, distal iris going out. Here we need the hook, the snare to pull out the loop outside, and then tying it by 2-1-1. It's very important here to have a good anatomy and just keeping everything clear. This first suture is going through the proximal iris. Second, the beginning, the proximal part of the loop is going to the distal iris, and this is the free end. So when we do our knot, we tie it to, and then we pull both sides from outside, and the knot ties inside. Try to minimize the tension just to prevent iridodialysis, and we repeat that again for another knot and another knot just to have 2-1-1 ties. This is a video that I got from the American Academy this year, presenting the single pass 4-throw pupilloplasty, which is easier than going to 2-1-1.
Let's understand how this procedure is performed. Let's mark the iris before we begin. To any iris defect, there is a proximal iris where you enter and a distal iris where you exit. Step 1. Make a stab incision on one side of the iris defect. This can be the distal incision. Step 2. A 10-0 proline suture is passed from the opposite side. This can be the proximal incision through the proximal iris and left in situ. Step 3. A 26-gauge needle is then passed through the distal iris. Step 4. The needle of the 10-0 proline is passed into the lumen of the 26-gauge needle and railroaded to the distal incision and pulled through to the suture end. It's now important to understand the suture trail as it traverses the iris. The trail consists of 5 parts. Part 1, external to the proximal incision. Part 2, proximal incision to the proximal iris. Part 3, proximal iris to the distal iris. Part 4, distal iris to the distal incision. Part 5, external to the distal incision. A loop of suture as depicted is taken from the part 2 of the suture, pulled out through the distal incision and made to lie on the conjunctiva. The part 5 of the suture is now cut, and the cut end is thrown into the loop of part 2 4 times, hence showcasing the 4th row of this pupilloplasty. Now, to tie the iris defect together, we take part 1 and part 5 of the suture pass and pull them away from each other externally. This pull brings about a helical pattern to the 4th row knot. Now, as the knot approaches the iris defect intracamerally, it brings the 2 sides of the iris defect closer. Finally, when the helix of the knot comes in contact with both the proximal and distal iris, it intertwines it all together to complete the knot. Now a micro scissor is taken and the suture cut close to the knot, thereby completing the single pass 4th row pupilloplasty.
So with the 4th row pupilloplasty, it's easier just to go in 4 times rather than doing the 2 on 1. I think it's easier. Haven't done it. This is a patient who presented to the clinic with who had a floppy iris syndrome during the surgery. The iris prolapse, lots of segment. There is a clear transillumination defect. Here we can see the haptic optic junction, which is clearly abnormal. Patient was very symptomatic. Here, the ideal treatment is imbrication suture, where we go with the suture, just engage the stroma without interrupting the pigment epithelium, and just tying it with a Siepser technique. So here we see it tied, and then we do proceed the same suture, just engaging the stroma without touching the pigment epithelium. And here, the patient doesn't have any transillumination defect and symptomatically free. Moving on to Iridodialysis Repair, I read a very nice paper by Priya Narang and Amor Agarwal with trocar-assisted non-oppositional repair of iridodialysis. Here, as you see, there is almost 2 clock hours of iridodialysis. 25 gauge trocar is placed 180 degrees in front of the area that we want to fixate. This creates a very contained sealed chamber, not to lose fluids. We can do it under aqueous, we can do it with under a cohesive or dispersive viscoelastic. Removing the blade now creates a space or a tunnel where we can introduce our 10-0 or 9-0 proline sutures. As we can see here, we introduce the needle and just engage the most distal part of the iris that we can reach. From the opposite side, we use a 30 gauge needle 1.5 millimeters away from the limbus, and just docking our 10-0 proline and getting it out. So we have already now one of the suture loops is already from the iris loop and out into the sclera, which is very accurate and easy to manipulate. It's a double arm, so this is the other part of the needle. We do exactly the same. We engage the most distal part of the iris, and then using a 30 gauge needle 1.5 millimeters away from the limbus to dock our needle out. Now, having both into the iris and out to the sclera, we can titrate the tension and lock our suture, then under and then we undermine it or bury it under the sclera, and we can cover it with a conjunctival flap, a conjunctiva. This is another way of doing this is the traditional actually way of doing the iridodialysis repair, where we do a surgical partial thickness scleral flap, and then we use the proline suture, double arm proline suture with a very similar technique, coming from 180 degrees away and then going in. This flap is really good because it covers the knot that we're going to do here, as you can see here, and this is tied with 10-0 nylon. Pupilloplasty looks simple, but actually very challenging. We need 4 paracenteses, as you can see here. Each paracentesis serves to suture 3 clock hours in a baseball or a spiral style. As you can see, we go in and out, in and out, and in and out. It's very important here to use with second hand an MST forceps to help to engage the distal part of the iris. When you go out, it's better to dock your needle with a cannula, just not to engage any fibrils of the cornea. After the 4th pass, we can tie the knot, and then we can titrate exactly how much, like the pupil that we want, the size of the pupil. Usually we use calipers to decide whether we're going which size exactly of the pupil. Usually preoperatively we check the other eye just to make sure that both eyes are very similar sizes of the pupil, and it's very important not to have a very small pupil, just to keep a good eye on the retina after the procedure. Here, we can tie the knot as a McCannel knot, which is tied outside, and we can use the new McAhmed knot, which is a combination between McCannel and Ahmed. You can see the video.
Hey, we've had lots of questions as to how we tie the McAhmed knot after making a CerClaw suture. So in this video, I'm going to show you how we tie and break down the McAhmed knot, named after a combination of Dr. McCannel and Ahmed. So at the completion of the CerClaw suture, we're going to make a 3-1-1 knot. And this is the part that's similar to the McCannel. We're tying both ends through a single paracentesis. Both ends of the suture are protruding through a single paracentesis. Now we're going to use an intraocular tire to grab onto one end of that suture. So we're pulling the knot, or the row of 3, into the eye. I'm going to grab one end of the suture with a traditional tying forceps outside the eye, then use an intraocular tying forceps to grab the other end of the suture inside the eye. So you can see here, if we put a little overlay in, through our single paracentesis, we've got one end of the suture being held outside the eye by a tying forceps. The other end of that suture is held inside the eye with the intraocular tire. And then we can pull opposite directions, one inside the eye and one outside the eye, and carefully constrict the pupil without putting any pressure on the iris or cheese wiring the CerClaw suture. Since this is a 3-1-1 suture, you got to repeat that motion 2 more times, each time throwing the single throw and then grabbing one suture outside the eye, the other inside the eye, and tightening up your suture. The only thing to be cautious of is, on occasion, that second throw will still allow a little constriction of the pupil. So once the suture is tied and you're happy with the pupil size, you'll end up cutting the ends of the suture using an intraocular scissor. You'll then need to remove the viscoelastic. In this case, I'm going to use a bimanual IA, but the suture is completed. So I hope that you've understood and can now go back and tie your McAhmed knot. Thank you very much for watching.
So this was a combination of McCannel and Ahmed. I thought it's a nice way actually of tying the knot. Moving on from suturing techniques to artificial iris implants, when you find that the iris defect is huge or large, we don't have enough permanent iris to suture, then we go for iris implants. Just going through the history, Peter Choice is the first person who introduced the thought of a prosthetic iris in 1950. In 1980s, Morcher started making iris devices. In 1996, Ken Rosenthal implanted the first Morcher iris device in USA. In the 2000s, Oftec began making iris devices. In 2002, Dr. Summit Intraocular Rensen began making custom iris devices. In 2005, Bozdieva reported the first acrylic iris device. And the new important thing in 2018, which is 2 years back, the FDA approved Human Optics artificial iris. So companies manufacturing artificial iris are Human Optic, Morcher, Oftec, and Reaper. We're going to go into details. Morcher implants, first of all, we have the aniridia rings, where we have these rings. They're actually a modified tension rings. We can implant 2 rings with overlapping rings to cover a full aniridia. It will solve the functional symptoms of the patient, but cosmetically doesn't help. Partial aniridia rings, where it covers a limited area of iris defects. Aniridia implants, which are basically lens iris diaphragm. It has eyelets that it can be sutured to the sclera. It solves 2 problems. It can help with aphakia, and it helps with the aniridia portion. partial aniridia implants, many implants. I won't go through all of these. I'm going to go through the main ones. First of all, I'm going to talk about Morture 96F. It's a modified capsular tension ring with a black occluder paddle. It covers up to 3 clock hours. It is very brittle, which is the drawback of this device. It's very brittle because it's made up of PMMA that was irradiated to become black, so it's very brittle. It's always good to have 2 Morture 96 if you're planning to do the surgery on the patient in case it breaks, so you have another device on the table. We can use the same size of the cataract incision, so this is actually a good option, reducing the risks of surgery since it's a small incision. This is a patient, also I took it from an article. This patient had also a floppy iris syndrome with transillumination defects. After surgery, they implanted a Morture 96F, which is here. As you can see, the inner border of it, it blocks all the transillumination, so we don't have any transillumination defect. Patient was symptomatically free after that. Larger defects, as we said, we can use other types, which is the 50F. Here we can do the complete iris reconstruction with 2 rings. It does not solve the cosmetic issue, but relieves the symptoms. This is actually a very good device for patients with albinism, where you know the albinism patient, they have a perfect stroma, but the problem is with the pigment epithelium where they don't have pigments. So placing 2 rings of 50F will help a lot to have a very good cosmesis. It's very functional to take off most of the symptoms. However, the patient will still be symptomatic because, as we know, the choroid and the retinal pigment epithelium does not contain functional pigments, so the sclera will still transluminate. Morture 67B is a lens iris diaphragm. It is used for larger defects with missing capsule and lens. It comes only in black color. It needs a very large incision, more than 10 millimeters. And the central optic is a functional optic where we have a wide range of diopteric powers. Morture devices are available in Europe and elsewhere, but are not available in the USA. Off-tech devices, it came in 3 models, the 311 and the Iris prosthetic system and the Artisan Iris Reconstruction IOL. The middle one, which is the Iris prosthetic system, was we need to lock it. It goes into the bag. It's very surgically challenging. It's currently not on the market because with the 3 years multi-center clinical trial that was run in the USA, the PMA application was rejected by the FDA because they were unable to inspect the facility that actually manufactured the raw materials. So it's not going to come to the US market, and actually Off-Tech stopped selling all their iris devices in the beginning of this year, January 2020. It came previously with 3 very bright colors, which is the green, brown, and blue. Reaper, a very interesting iris lens diaphragm device made in Russia. It came in multiple designs, many colors, cosmetically very nice, and I'm going to go through that. I'm going to present a video that was done here by Dr. Beg in the Eye Institute, and then talk more about Reapers. So here we had a patient who had ruptured globe, corneal scar, prolapsed lens into the anterior chamber, IOL into the anterior chamber, superior iris was lost. We did a partial trephination here, and then small opening and staining with Kenalog just to do a proper vitrectomy before opening the wound. So vitrectomy was done, and then maybe here now we are preparing the Reaper iris lens diaphragm with Gore-Tex sutures, making sure that everything is ready, opened almost 5 clock hours, and then explanted the prolapsed intraocular lens outside. Here we, using a forceps, we inserted the Reaper IOL iris diaphragm. It's very important here to be really to really concentrate and not to mix up spaghetti. So it's very important to know where to get each suture out, each Gore-Tex suture out. Here we're using the MST forceps to get it out, and we created the opening previously with the marking. Here we inserted the Repair device. Securing it and tying the Gore-Tex sutures, and then these sutures should be buried, covered then with the conjunctiva, opening up the cornea with corneal scissors, removing the old scarred cornea. We're open sky here. This is the new cornea. Closing with 10-0 nylon. And you can see here the superior part is the Repair central optic. Inferiorly, you can see this is the original iris of the patient, a very clear cornea. This is the same patient. As you can see, here's the corneal scar, decompensated cornea, rarely can make up where is the IOL, only inferior remnant of the iris, and here is the post-op. Cosmetically really good. Going into details about Repair artificial iris, it's made up in Russia. It's a combined iris implant with IOL as a single device. The diameter is either 13 and 13.5 depending on the model. It's made up of hydrophobic acrylic. The central aperture is fixed on 3.5. Incision size as small as 2.8 if it is inserted with a special cartilage. Can be implanted in the ciliary sulcus or inside the capsular bag. Advantages: it combines artificial iris with IOL into a foldable complex. Relatively small incision, between 3 millimeters when using a cartilage, 5.5 when using a forceps, and decreased ocular manipulation as we have a small incision, so less sutures and then less induced astigmatism. The advantages for the patient is that it's more natural looking appearance. There is marked reduction in the light sensitivity, and comparing the prices for the patient, significantly less expensive compared to other customized artificial devices. It's about 10 to 20% of the cost. This is another picture that was also done in the Eye Institute. Here we have picture A, where this is an aniridic patient with a cataract. Cosmetically really looks good with the Repair. Another patient which had a superior iris defect, and then second picture shows a cosmetically very acceptable look. Moving on to the most recent type of iris implant, which was just FDA approved, the human optics. It was a brainchild of Hans Richard Koch. It's initially manufactured by Dr. Simit Intraocularsen in Germany. It was licensed and later sold to Human Optics, distributed in the USA by VO Ophthalmics. It's a custom manufactured, flexible, biocompatible. It's made up of silicone. The template is a photograph of the normal fellow eye, or it can be, if the patient is aniridic in both eyes, it can be a picture of a celebrity or a family member. There is no integrated optic like the Morcher optic and Repair devices. So this is a better picture showing the dimensions exactly. It's at 12.8 millimeters in diameter. The pupil diameter is 3.35 millimeters. It is thicker paracentrally, where it is thicker here, and then it's almost 0.4 here, and then when it goes to the periphery, it's thinner. It comes into two models, fiber-free and fiber-containing. The two models can be fixated in all fixation spots, like back fixation, sulcus fixation, and without suturing, and sulcus fixation and with suturing. The only difference is that if we plan to suture our IOL to the posterior aspect of the implant, we should order then the fiber-containing, which is a more challenging device to handle. Methods of fixation, it can be either a passive fixation where we don't suture it. Here we can put it in the capsular bag or in the ciliary sulcus, but keeping in mind, when we don't suture this device in the ciliary sulcus, we definitely need a good anterior and a posterior support to prevent migration of the device later. Actively fixated, sutures to the sclera, suture to the IL, which is then later suture to the sclera, or it can be a suture to the residual iris. So here, let me just take this here. So fixating the human optics in the bag placement, we need an intact anterior and posterior capsular bag. A capsular tension ring must be placed in the bag before placing the device, because if we don't place a capsular tension ring, then the capsular phimosis can result, extruding or buckling this device, the implant outside, buckling the implant within the bag, and then we can't yag the anterior capsule, because if we yag it, the whole implant might prolapse forward. So basic technique is going into phaco, IOL in the bag, make sure that the rexus is 5.5 to 6 millimeters, and then place the CTR, and then measure the bag with a special ruler, and getting the exact measurement by lining up the Purkinje images, and then the number that we get, we can multiply it by 2 and subtract by 0.5 to get the exact trefination that we're going to use. We have to use vision blue just to visualize the anterior capsule, as we lose the red reflex when we put these devices. Artificial iris is then inserted within the bag. If you're just starting, it's good to start with not larger than 9.5, because it's at that point, if it's larger, it's going to be difficult to manipulate. Sorry. Here you can see this is the bag. We can see the capsular tension ring and the iris device within the bag. In the sulcus placement, IOL is already in the bag, and then passive fixation, if we have plenty of support from the iris and the IOL, we don't need an intact capsular rexus, but we definitely need a good support at the back with a bag. We can also actively fixate it with a 9O proline or Gore-Tex suture. It's large iris implants, it's 12.8, so we have to make sure that it's all under the original iris, and we have to use an OVD to protect the endothelium. Remember that patients with aniridia, they might seem on examination as they're totally aniridic, but they still have a rudimentary iris and the angle. So let's make sure that we make sure that the artificial iris is actually under this rudimentary iris. Here you can see the patient having, this is the original iris of the patient, that is, we're having an iris defect here. This is the sulcus placement of the iris. The human optics, if we place it with no support, we have plant suture fixation is best with fiber design, but we can still also suture the fiber-free design. IOL can be suture fixated to the posterior aspect of the fiber implant, and then we can fixate the IOL to the implant by 9O proline and fix the implant by 9O proline or Gore-Tex suture to the scleral wall. This is a very nice picture where you can see that the 3-piece IOL is posteriorly fixated to the implant by 9O proline, and then another 9O proline is used to fixate the implant to the scleral wall. This is human optics artificial iris IOL complex starting. Done here again in the Eye Institute. This is the human optics foldable artificial iris, getting it out and making sure that we trephinate the exact size that we need. We proceed with trying to maximize the centration, just to make sure that the pupil is in the center, trefining and making sure that the ring, the peripheral ring, is not attached anymore. This is how it looks. And then here we're making sure that the ring, the peripheral ring, is complete. And then now with the 3-piece IOL, we create now like 2 parallel cuts for the haptic, just to introduce the haptic of the 3-piece IOL. As you can see here, this is called a belt loop, the belt loop fixation of the 3-piece IOL. Fixating one of the haptics, going for the other haptic without suturing. As you can see, the IOL is fixated, very well centered to the pupil. I'm gonna proceed for the same patient intrascleral fixation. Here, as you can see, this was combined. This is a traumatic aphakia and iridia, corneal scarring of a previous PK. It's very important for the toric markers to mark 180 degrees, just as to know the exit points of the haptics. Here we're doing the T-shaped scleral incisions, and then pockets for future haptic tucking. Ensuring the proper sizing, which was done even before trephination, anterior vitrectomy. And then here incision is created for the haptic exits on both sides, 180 degrees apart. This is a 23 gauge forceps. And then now creating an opening approximately 5 clock hours of the cornea. Introducing the human optics IOL complex now. And then extruding the haptics outside under the tunnels, proceeding with a penetrating keratoplasty. This is an open sky. And then here, proceeding with 10-0 nylon interrupted sutures. This is the final look of the patient. Cosmetically, it looks exactly like the other eye. This is a picture of a patient that I got from Dr. Kevin Miller surgeries. You can see here, it's really, you can't tell the difference between the two eyes. It's this is the pre-op picture and this is the post-op picture. It was matched to the other eye. This is another picture. As you can see, it's really symmetrical and very similar to the other eye. So now, since I have talked about all iris prostheses, when you have a patient with iris prosthesis, when you want to decide which implant to use, you have to put in mind many things. You have to think about the phakic status of the patient. If the patient is phakic, it might be done with a cataract surgery. If the patient is aphakic, and you can use the IOL like iris lens implants, and if the patient is pseudophakic, you can go with either. Integrity of the capsular bag is also important in the in planning the surgery. Severity and the extent of the iris defect, whether it's 3 clock hours, 3 to 6 clock hours or more, and the cosmesis. Complications of prosthetic iris devices. Intraoperatively, we have the implant-related problems such as broken implant. As I told you, the modified CTRs are very brittle. Implantation of a prosthetic iris device in a suboptimal site, like if it's anterior to the iris, or if it is implanted in the angle, or if we get a PCR and then it migrates to the vitreous. If we get a capsular tear, hyphema, because we manipulate with the iris, and usually it's self-limiting. Post-operative complications are raised intraocular pressure, prolonged inflammation since we're dealing with the iris, corneal decompensation, malpositioning of the implants, vitreous hemorrhage, retinal detachment, hypotony, endophthalmitis, and cystoid macular edema. Very important not to be confused with cosmetic artificial iris. Many companies outside into advertising for changing iris colors, many, as you can see in on the PowerPoint, you can here see iris implant, add colors to your life. Here, change the color of your eyes without any risk, which is totally not true. And then here in some of the countries, we have other pictures of changing the color of the iris. You can see on this website, introducing iris implants, which are in the anterior chamber, which may induce many problems, as we're going to discuss. This is a patient who had a surgery elsewhere to change the color of the iris. Here, I think they're introducing the myocol, viscoelastic, and then introducing the artificial iris only to change the color in the anterior chamber. As you can see here. So this is basically the surgery. You can see the patient post-operatively, bilaterally. Patient came with cataracts in both eyes, endothelial starting to decompensate, where you can see the cell counts, and uveitis in both eyes. Explantation of both devices were done. I'm going to show you the video here. This is the right eye. paracentesis, myocol or myostat just to constrict the iris to protect the lens, and then starting this three-step incision, crescent blade and OVD into the anterior chamber, opening up our incision with a keratome, and then here using the we're cutting the device using the MSTs with the scissors and the forceps, and then using, on the other hand, a cannula to try to protect the endothelium while pulling this device out, not to touch the endothelium. First implant was removed. This is the left eye. Same procedure, cutting this iris the iris implant, and then removing it, trying to protect the cornea with the cannula of the viscoelastic. Thank you.
All right, thanks, Wadha. That's a nice, real overview, a succinct overview of, I guess, the full spectrum of what to deal with in terms of iris defects, whether it be anywhere from tattooing, cosmetic contact lens, special glasses, all the way to iris repair with suturing,
Yeah.
to implants, whether it be therapeutic or cosmetic.
Exactly.
And so some questions I had for you had to do with, a question we often get is, if you have some iris there, some natural iris, do you remove it? Do you leave it in place when putting an implant in?
Yeah, so some of the time we remove the pupillary margin because it tends to be darker than the implanted artificial iris. This is for a better cosmesis. Sometimes in patients with eye syndrome where it's a non-functional iris, then we tend to remove what is remaining from the iris. Otherwise, if it's only a partial, like involving some clock hours, we can leave the rest functional iris.
Okay, and what are some of the things that you counsel patients on when deciding what kind of iris implant to put in? So suppose they're going for a Reaper or a custom flex, artificial iris. What are some important things to talk about with the patient?
So it's very important to mention for the patient the incision size we're going for with each device. Some devices need a very large incision, inducing more astigmatism, more intraoperative complications. Whether other devices where they can be inserted only with a cartilage, very small incision, inducing less astigmatism. It's very important also to see the cosmesis. If the patient is really concerned, then we can do the custom iris devices. If the patient is okay, then we can do other devices. Another important thing is to see if the patient is having comorbidities, such as if the patient is having is an aphakic patient, then we can go for the iris implants that have already integrated with an optic, which might be functional at that point.
Okay, and how about counseling on the color? Like some patients who are bilaterally aniridic.
Yeah.
What's the discussion like there?
So for patients who are bilateral, we had patients with bilateral aniridia. They choose one of the family members to be like a model for their eyes. This request definitely can be done. Like we take a photo, an anterior segment photo of the preferred iris color. If it was a brother, a sibling, or if it was a mother or a father of the patient, then they want to have this color of the iris. We take an anterior segment photo and then we send it to the company. It takes 2 months for manufacturing the exact same. If a patient has only one eye that is aniridic, then we can do the other eye. If they have a celebrity that they want to do the eye, this very similar eye, then they can do that too.
Yeah, I think another thing that it's, I guess we have various countries on the as audience members here. So for us in Canada, many of these devices are not Health Canada approved, so they do require on a case-by-case basis special access. So that does lead to some extra time. So it has to be something that's, obviously planned in advance.
Yeah.
And so what another question is, you had mentioned the instruments. I think the key to a lot of this is the instruments. Can you comment on what, for people who have not done this before, what's really important in terms of instrumentation, in terms of controlling the eye, in terms of what are the real essential parts in the toolbox that you need?
Yeah, so regarding the instruments for iris suturing techniques, it's very important if we're going for a Siepser technique to have we use a snare here, to pull the loop. It's very important to have the needle that you want to. So in pupilloplasty, if we go for the straight needle, then we have a better control because we're going to 360. MST is very important just to have a good forceps, to have a good grip on the iris, on the pupillary margin, just to engage the needle and just to have the spiral loop of engagement of the needle. I think if we don't have an MST, then we can go for the McCannel, but this works only for the peripheral iris defect. It doesn't work for the central ones.
Okay. And of course, any questions from the audience members are welcome. What about the sizing of these? Because you had mentioned how important it is to make sure the size of the artificial iris is appropriate, because you don't want to have tissues like the implant touching tissues and causing inflammation.
Exactly.
And so you had mentioned for in the bag measurements. How about if you're putting in the sulcus, what would be the most appropriate way to measure that?
So if we plan to put the iris device in the sulcus, then we consider the horizontal and the vertical white-to-white distance. So we usually depend on the vertical white-to-white and subtract 1. So let's say that it's maybe 12 or 13, the white-to-white, the vertical, then we take we minus 1 and then we refine according to that size.
Okay. Question from Batish. Excellent conference at Wadha was very informative. What do you think is the role of pupilloplasty in angle closure glaucoma?
So I have never encountered a patient just to pull the iris away from the angles. Haven't done this. I don't know if it improves the angle. Actually, if it was already synechiaized, like if it was already formed synechia, I don't know whether pulling that iris would help. I have to read about that.
Yeah. Okay. There's also, maybe you can comment, there's a certain role for when you have an iris, sorry, you have a pupil that's eccentric, so it's not quite straight in the middle. You know, the use of intraocular cautery.
Yes, exactly.
To kind of help center a non-centered pupil. Do you have any comments about that?
Yeah, so if we have a peaked pupil or an eccentric pupil, it's first of all, it's better to see why is it eccentric or peaked. Make sure that it's not a vitreous in the AC that's pulling the pupil that way. If it's fine, then we can use the intraocular cautery. It's the same as what we used back in Kuwait was the Centurion. So it's basically just creating very minimal burn, starts with a very low power. When you do the cautery, you need to do it in multiple places. It pulls the iris where you do the cautery and titrate accordingly. Sometimes if you go very aggressive, then it causes some transillumination defects, and sometimes it creates even holes in the iris. So you have to start with very minimal power and titrate accordingly.
Right. Thank you. And what about when patients, like right before the OR, are there certain things that you look for in a patient before going to the OR to say do a iris repair in the involved eye? What are some things that you would want to review, or what do you think would be beneficial for surgeons who are thinking of doing this that they should look at before going into the OR?
So I would definitely do only symptomatic patients. So if the patient is really bothered, really symptomatic, then I would proceed for the surgery. I would look at the other eye just to have a good idea what I'm planning. So if I'm doing a cerclage, I will look at the other eye just to titrate the pupil size and tell the patient that if it's not going to be the same size, I'm going to tell the patient while counseling the patient that it's going to be of this size, which might be different from the other eye. Telling the patient also about the possible complications, what to expect, a long-term, like a few months at least, of anti-inflammatories. I think this is basically what we need preoperatively. Intraoperatively, before starting the procedure, is really important, because when I go in, I want to check the viability of the iris. I want to check the flexibility. I want to see the the stretchability of the iris, if I can fix or not before proceeding into the surgery, and trying to do only very, very minimal tension just to prevent inducing another iridodialysis or bleeding intraoperatively.
Yeah, I think the one key point you mentioned is letting the patient know about sizing, because some patients think it's going to be a fully functioning pupil, so you got to let them know it's a fixed size.
Exactly.
You have to make sure, as you mentioned, for retina purposes, that your retina colleagues are happy with you going ahead with this. So I sometimes consult them to make sure it's going well. And sometimes even right before the OR, I look at the other eye, and when the patient is kind of upright, to see how low the upper lid goes.
Okay.
Sometimes, there's some, you can do a whole lot of work to make it look absolutely perfect, but sometimes when people have upper lids that are kind of low, it can often cover some of the things that you want to do in terms of iris repair. So I find some of these things useful as well as what you have mentioned. All right, any other questions from the audience? Anybody have questions here? Okay. Now, one other question is, do you think that this is in the realm of a cataract surgeon's skill set, or should this be really someone like a retina person or an anterior segment person, a cornea person should be doing these cases?
I definitely think it's not a retinal surgeon, since it's in the anterior segment, and it's not for a comprehensive ophthalmologist who does only cataract surgery. I think it's more of an anterior segment complex surgeries, because handling the iris seems to be easy, but manipulating in the anterior chamber, preventing any touch to the cornea, working in a very close space, I think it's more of an anterior segment surgeon.
Okay, cool. All right, Dr. AlSaadoun, thank you so much for this nice overview. I think it'll be referred to a lot in our YouTube channel, so thank you very much for the time you spent preparing it and the time this evening sharing with us your presentation.
No problem.
Have a great night. Thank you.
Thank you. Thank you.
That's good.